Well, thank you everybody for showing up. We're going to get started now. We're here to talk about managing gastroparesis safely, and in particular medication risks for a condition called tardive dyskinesia. And we have with us two very special people from the National Organization for Tardive Dyskinesia. I'm going to read your introductions. So Bill Coate, who's going to start us off, is the executive director of the National Organization for Tardive Dyskinesia. He presents on TD to patients and advocacy groups with an extensive background in communications. He's worked as a professional writer, grant writer. He's earned a BA in creative nonfiction writing from South New Hampshire University. And April Kraft is also here. She's the TD support specialist for the National Organization for Tardive Dyskinesia. She moderates NOTD's virtual support groups. Through her family and personal health care journey, she's discovered that patients need an advocate on their side. She's participated in several Hill Day trips to Washington, D.C. to advocate for TD awareness and policy issues. Thank you, Bill and April, for being here. Why don't we get started? Bill, you can go ahead and share your screen, and I'll be watching the chat and making sure no one's stuck in the waiting room or anything like that.
Okay, let me give this a go here.
Okay.
Here we go.
Moment of truth.
Okay, great.
It's all
Thank you.
slides.
All slides. That's all we want. All slides, all day long. Okay, let me move everyone away. Okay, so it's a pleasure to be with everyone today. Thank you for your interest in learning more about an involuntary movement disorder called tardive dyskinesia. As Jim was explaining, it's also referred to as TD for short. They can affect those with gastroparesis if you're taking metoclopramide or Reglan, as it's also known. And my name is Bill Coate, the executive director of the National Organization for Tardive Dyskinesia. The presenter for the second half of our program will be April Kraft, our TD support specialist. And just a quick note, please remember that this webinar is for educational purposes only. It's not intended to replace medical advice. Treatment decisions should always be made in partnership with a qualified healthcare provider based on individual circumstances. So what in the world is tardive dyskinesia anyways? Well, the word tardive means late onset, and dyskinesia means involuntary movement. So tardive dyskinesia is an involuntary movement disorder that doesn't start until after you've been on a medicine for some time. For people at average risk, this is usually at least 3 months of being on a medicine that can cause TD. But we'll go through risks a little bit later on, and talk about how it can appear in less than 3 months. TD can cause movements in any muscles from the face to the feet. These are involuntary repetitive movements of the face, limbs, torso, or other body parts. TD often primarily affects the face, especially the mouth, tongue, or jaw, and we call those orofacial movements. These can be very distressing for those exhibiting these movements. The tongue will frequently start moving on its own constantly, or even dart out of the mouth, and the lips can grimace, or the mouth can often open repetitively. So as us as human beings, as we're so tuned in on people's faces, you can imagine how that would could make the person who is exhibiting these movements embarrassed or uncomfortable, or even create some stigma. Now, TD is an involuntary movement disorder caused by medications that block dopamine D2 receptors in the brain. Most commonly, TD is caused by antipsychotic medications, which are used for a wide variety of mental health conditions. However, it can also be caused by anti-nausea meds, such as metoclopramide, which is the only FDA-approved medication for gastroparesis. Now, why are medicines that block dopamine used to treat gastroparesis? Well, dopamine blocking agents stimulate stomach contractions, accelerate gastric emptying, and relieve nausea. So they are useful in the management of gastroparesis. Some medications that block dopamine receptors include antipsychotics, as previously mentioned, but there are other classes of medicine, including prokinetics and antiemetics, um, such as metoclopramide is both a prokinetic and an antiemetic. Um, and it's, as I said before, the only FDA-approved medication specifically indicated for the treatment of gastroparesis. Now, Reglan, as it's also known as, blocks dopamine D2 receptors in both the central nervous system, primarily in the brain, and the upper gastrointestinal tract, promoting gut motility and reducing nausea. Because metoclopramide crosses the blood-brain barrier, it does carry a risk of side effects, including Parkinsonism and tardive dyskinesia, and it typically carries a maximum treatment window of 12 weeks. There's a few other medicines that we mention on here on the slide. One is called domperidone. Now, that's a prokinetic that's widely available outside the U.S. In the U.S., it's not FDA approved, but it can be obtained through what's called an FDA expanded access or investigational new drug program. Um, it blocks D2 dopamine, but it acts directly on the stomach and the zone outside the blood-brain barrier. Because it's not readily affecting the brain's D2 receptors, there generally should be no worry about it causing TD. However, if a patient does have issues with blood-brain barrier permeability, there could be effects on the D2 receptors in the brain, and that's, again, what we're worried about with TD. Other medicines that fall under the heading of antiemetics, um, there's ones phenergen and colchicine are common, and they are dopamine blocking agents used off-label as rescue antiemetics to relieve severe nausea and vomiting associated with gastroparesis. Now, unlike metoclopramide, these agents do not accelerate gastric motility or emptying and are strictly used for nausea control. Now, there is one other drug that you might run into that's not mentioned on this slide. It's called Zofran. Now, it doesn't block dopamine, so it shouldn't cause any TD. However, there are rare reports of a dystonic movement reaction when it is received intravenously. So, why does TD develop in the first place? The leading theory of TD is that the body tries to overcome this blockade of D2 receptors by making these dopamine receptors hypersensitive. If these hypersensitive receptors are in the movement center of the brain, known as the basal ganglia, it can cause TD. At least that's the prevailing theory. And over time, this causes these unintentional, uncontrolled movements. So it usually takes at least 3 months of treatment, as I mentioned earlier, with these dopamine blocking medicines for TD to start. And that's why metoclopramide has a warning not to take it for more than 12 weeks at a time if you're at average risk. For many people, it could even take years. If they're on antipsychotics, it could even take years for TD to appear. However, in those who are at high risk, especially seniors, it can only take a month or even less for a dopamine blocking medication for this movement disorder to appear. And we'll talk a little more, like I said, about risk factors later. Experts estimate that only about 35% of TD cases are formally diagnosed. Sometimes this is because a person could be taking a medicine for a very long period of time, years even, when all of a sudden movements or symptoms appear. And this makes it more difficult for healthcare providers to connect these new symptoms to the medicine that they've been taking. That is now producing these side effects. So some symptoms like difficulty swallowing or breathing are often not identified as TD, and this can cause difficulty receiving a proper diagnosis. So early detection and education about TD. TD can be very distressing and cause embarrassment or stigma to the person experiencing this involuntary movements. In addition, it can affect activities of daily living, such as typing on a keyboard, or buttoning clothes, or holding a coffee mug without spilling. So people may also be so embarrassed of their movements that they're making that they may not want to go out in public when they're having an episode. That's a big reason why early diagnosis is important. In many cases, TD can be treated and thus help avoid the emotional toll that it can take. If caught very early, it can slowly dissipate. However, in many cases, it unfortunately can become permanent. So this is something you'd want to be, if you're on metoclopramide, be very vigilant of. And if let your family members or caregivers know that if you have one, that if you see me making these movements, because a lot of times the people who have TD don't even know they're making the movements, let me know. So there are now FDA approved treatments for tardive dyskinesia that help to reduce or sometimes eliminate the movements of TD. So that's good news. But TD is in the FDA's black box warning for metoclopramide. The FDA mandated black box warning on metoclopramide or Reglan centers on the risk of tardive dyskinesia. It highlights the following key points: that there is a risk of irreversible movement disorders, such as tardive dyskinesia, a serious neurological movement characterized by involuntary repetitive body movements, particularly of the face, tongue, and extremities, that is often irreversible. Now, the risk of developing TD increases with the duration of treatment and the total cumulative dose. So there's a 12-week threshold with people who take it for gastroparesis. Taking it any longer than 12 weeks should be avoided in all but rare cases where the therapeutic benefit is thought to outweigh the risk. So metoclopramide therapy must be discontinued immediately if the patient develops signs or symptoms of tardive dyskinesia. There's also the black box warning talks about a contraindication. It's strictly contraindicated in patients with a prior history of TD or in vulnerable populations such as elderly patients, especially elderly women, and in patients receiving higher doses, long-term therapy, or also if they take antipsychotics at the same time, they would face the highest risk of developing TD. The good news, like I said, is that if you stay within the 12-week treatment window and you are of average risk, meaning you're not over 65 or female or some of the risk categories that we're going to get into, your risk is actually only 0.37%, according to a really recent study that was published this year. They used to think that there was a much bigger risk, between 1 and 10%, which is a really large window. So that study was very helpful in helping us understand, and everyone understand who takes these medicines, that the risk is not nearly as large if you're at average risk and you stay under 12 weeks. The risk increases substantially, again, with total cumulative dosage and treatment duration. And that's why the FDA issued its box warning, recommended that it not be used for more than 12 weeks in almost all cases. So one of the things that you're probably familiar with is that people with gastroparesis who take this medicine, they take these drug holidays, these planned breaks from metoclopramide every 12 weeks. And that allows the body to time off from the dopamine receptor blockade, which may help lower the cumulative drug exposure and reduce the likelihood of TD. This drug holiday usually lasts between 2 to 4 weeks. And the temporary break allows the receptors time to reset, and reduces the cumulative drug exposure and lowering the long-term risk of tardive dyskinesia. Now, the risk factors I kept on talking about, uh, for TD, being an older adult, over 50 years, and as you go higher and become older, the risk gets higher. So oftentimes you'll maybe hear with metoclopramide that it's more of a 65, anybody over 65 has to be worried. But really, in the TD world that we work in, anybody who's older than 50, has to be a little careful with being a high risk person. And that risk is increased if they're female. So, and the reason why seniors, they believe, have this higher risk is that it's age-related decline in kidney function. That means that metoclopramide would stay in the system longer, leading to higher active drug concentrations and an increased total cumulative dose, which is the primary driver of TD risk. Um, This also applies to other things, beyond just TD. Older adults taking metoclopramide also face a higher likelihood of experiencing Parkinsonism, which would be another type of movement, which would be exhibited as tremors, muscle rigidity, slowed movement, or severe restlessness, which would be akathisia, confusion, and balance issues that increase fall risks. So the main risk categories, really, there's a lot written there on that slide, but really it's especially people over 65, females, patients with diabetes or renal impairment, and if you are also taking some other type of dopamine receptor antagonist, is what they call it, such as an antipsychotic or certain anti-nausea medicines. So there's a few other risks here too. History of alcohol or substance abuse, being a smoker. So it's important to know the risks, but let facts, not fear, drive your decisions. For people living with gastroparesis, medications can play an important role in managing symptoms and improving quality of life. So, understanding the potential risks, recognizing the warning signs, and having open conversations with your healthcare provider empowers you to make informed decisions about your own care. Many medication used in chronic illness require ongoing conversations about the safety and effectiveness of these meds. So, we talked about the drug holiday. During this 2 to 4 week period when you're off of metoclopramide, there is an alternative management kind of approaches that doctors may use. And because these gastroparesis symptoms may resurface during the drug holiday, um, you may often work with your gastroenterologist to temporarily switch to an alternative prokinetic agent like erythromycin, using a non-dopaminergic antiemetic like Zofran, or strictly adjusting your diet using eating smaller, low-fat, low-fiber meals. Um, Now, tracking your symptoms is really important. It plays a crucial role, and communicating any changes that you see with your healthcare team immediately is the best advice. Because again, TD can become permanent if it develops. So it's important to monitor for any unusual movements you may experience. We encourage patients to advocate for regular medication reviews and shared decision making. After all, it's your body. So you should play an active role in discussing your treatment plan and asking questions about any medicines you take. And finally, so before I hand it over to April, I have one more slide, and this discusses other movement disorders besides tardive dyskinesia. So tardive dyskinesia affects about 800,000 people in the U.S. alone, which sounds like a big number, but actually essential tremor is the most common movement disorder, and that affects an estimated 10 million people in the U.S. It's up to 20 times more prevalent than the Parkinson's disease, which is quite widespread. And primary symptoms of Parkinson's include involuntary rhythmic shaking that most frequently affects the hands and arms, but can also involve the head, neck, chin, or voice. So Parkinson's disease is characterized by tremors, muscle rigidity, and slowed movement. It is referred to as hypokinetic, while TD would be referred to as hyperkinetic. Those with Parkinson's may also exhibit a mask-like facial feature where almost no movement occurs. Um, Dystonia is another movement disorder. It's another neurological movement disorder characterized by involuntary muscle contractions. These lead to slow, repetitive movements, twisting, or abnormal postures. The final one that we listed here, even though there are many more movement disorders, is one called akathisia. And that's a movement disorder that entails signs of severe agitation, a restless desire to keep moving, or the need to pace back and forth. Um, it can cause an overwhelming desire to move in the lower or upper body, and it can be accompanied by feelings of dread, actually. So there's a psychological component as well. Those with akathisia have described this disorder as a terrible feeling of actually wanting to jump out of your skin. So it can be very incredibly uncomfortable. Well, these are just a few of the many movement disorders that exist. I'll stop sharing so that April can jump on here and do the rest of the presentation.
Thank you so much, Bill. Really appreciate all of that. Um, April, whenever you're ready. And folks, we'll be able to get to questions. When April's done, we should have about 15 minutes, 10, 15 minutes for that at the end. While April's queuing up, Bill, I'm curious if akathisia is the same thing as like restless leg syndrome.
Well, there is that restlessness. You make a good point. That is much more common. This restless leg syndrome is really common at night.
Hmm.
Um, but it's not the same at all. It's
Oh,
much more distressing. Akathisia has this sort of like it can really manifest itself not only in the legs but in the upper body. It'll make you just want to walk, 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 which there is some similarity there. So there are some similarities, but restless leg is thankfully not nearly as really it could be described as horrific sometimes, akathisia. It's really a very difficult one. Yeah, so I just mentioned it because,
yeah.
more is becoming known about it. It was for a long time misunderstood as purely just a movement disorder, but it has those psychological components as well.
Thanks for clarifying that, Bill.
Sure.
April, you all ready to rock?
Yeah, can you confirm that
Yeah, I can
that
see you.
slide and only slide?
Yep, that's right.
Excellent. Bill, thank you for passing the torch over to me to present the next section. And I am going to go over, recognizing the signs and symptoms of TD. I myself live with TD. Um, so I can speak from experience and also from what I have learned from the numerous people that I have had the pleasure of meeting, and learning about their journey and their stories, and also the clinical information that I've learned along the way. Signs What to watch for. You want to watch for any unusual involuntary movements. Uncontrollable movements caused by TD often affect the eyes, face, or mouth. And those are the well-known or hallmark symptoms or movements of the disorder. So strange movements of the tongue, I believe Bill mentioned, random movement of the tongue. Sometimes the tongue will dart out or, movement outside of the mouth, rubbing lips together, almost like you're constantly rubbing in some chapstick, grimacing of the face. If you can think of, something you really don't like and it gives you that ick feeling, and that would be the grimace that the TD movement might be like. There might be mild to severe twitching of facial muscles, and also fast blinking of the eyes, and almost to a squint, or even they can essentially remain closed. And one of the things that is good to know, very important to know about TD, is that it can affect any skeletal muscle in the body. So there are other signs to watch for as well, and other regions of the body. TD can also cause shaking or jerking in the hands, feet, or torso. Those TD movements, particularly in the hands, often see fingers moving in a fluid fashion that almost look like one is playing the piano, and is coined piano fingers. And it's a 3D, almost a 3D movement. If you think of like moving your fingers in a wave, unlike a tremor, like a central tremor or a tremor that you would witness someone with Parkinson's disease present with, it is more of a left or right or up and down, which is considered two-dimensional. There's also toes. I cannot forget the toes. Just like the piano fingers, you can experience involuntary movements in the toes, where the toes basically grip the floor or shoes, or they may also move in a fluid-like pattern, like the fingers with the piano fingers. And that has been coined dancing toes. Another movement that's common in throughout the body is thrusting of the pelvis, which basically moving the pelvis forward and makes the back arch. So that's the most likely, they're the most visible in that movement. There's also a pain or sensory syndrome that can be associated with tardive dyskinesia. It's a burning pain in the mouth or genitals, and it can often be misdiagnosed, particularly in the mouth, as burning mouth syndrome, which is separate. So the effects of TD, when the movements affect the tongue and the mouth, can develop sores in the mouth from biting the tongue, the inside of the cheek, or biting lips. Speech impairment or involuntary grunting. The speech impairment is due to the uncontrollable tongue movement. When we speak, we move our tongue a specific way, and the involuntary movement of the tongue impairs that specific movement. Dental damage can occur from clenching or grinding the teeth, known as bruxism. Intensity can be so great that people have broken teeth, and that, of course, causes dental pain. Also, the clenching and grinding and just tension of the muscles can cause pain in the temporal mandibular region of the jaw. Other effects of TD that frequently happen: difficulty chewing, swallowing, or drinking. And again, there are an incredible number of muscles involved in movement that impact our daily activities of living. If uncontrollable movements affect the tongue, eating can be difficult because it's hard to clear food from your mouth when you swallow. The tongue muscles help move the food along to the esophagus. And this is one of those, this is an impact where someone might feel very conspicuous in public, eating at a restaurant, if they're unable to clear food from their mouth. Gait or balance issues, using the muscles that we do for maintaining how tall we stand, standing up straight and balance while we're walking. And honestly, even standing still, we have to maintain balance. Those are skeletal muscles as well. And if those muscles are affected by TD, they're going to have a hard time performing their usual function when moving uncontrollably due to the disorder. Visualizing it, for me, it's almost like a chaotic internal bout of tug of war. You want to move one way and the muscles move a different way. They're just going where they want to go. And that would be the basic reason for gait and balance issues. Breathing complications and respiratory dyskinesia. There are quite a number of skeletal muscles that are involved in breathing and respiration. The muscles between each rib, of course, the diaphragm as well, can be affected by TD. And so experiencing issues there can complicate breathing, can leave one feeling short of breath when walking, and discomfort. And general muscle pain and discomfort, if you might imagine your muscles moving uncontrollably all day, that is going to cause discomfort and muscle pain, much like if you were doing an intense workout. Your body is doing that all on its own. Cognition and thinking issues often come along with TD. The cognition issues occur due to the common neural pathway in the brain that the dopamine 2 receptors use for both movement and cognition. So they can create brain fog and problems with memory, comprehension, and mostly short-term memory. So the overall impact of TD on the population, Bill mentioned that the latest estimate is around 800,000 people suffer from some form of TD. Only approximately 40% of people with TD have been diagnosed. Over 75% of people with TD severe impact on physical, psychological, and social well-being. It can have such a dramatic impact on quality of life. So just over 75% of people with TD surveyed, it was about 269 people total, said the disorder has a severe impact on their physical, psychological, and social well-being. Even a mild case of TD can make you feel as if the world is aware of your every movement. Almost half of those with TD surveyed said they were often or always stared at or asked, "What is wrong?" or "Why are you moving?" Almost 54% of those surveyed often or always felt sad or unhappy because of TD. 45% of those surveyed said TD prevented them from leaving the house in the previous week. So additional things, additional groups of those people, they just felt completely embarrassed. And I know what that feels like as well. It's like, gosh, what must people think when they see, contortion of my face. Um, so uh, I understand that impact. TD makes it challenging to take care of what would be simple tasks. That's something Bill mentioned as well. It can be difficult to handwrite notes or a letter. Holding a pen can be difficult. It could be difficult to type. It can also impact other tasks that many of us do daily: washing dishes, brushing our teeth, putting on tennis shoes and having to tighten the laces and tie the shoestrings. So just those little things that we do for ourselves can become very difficult. Some of the risk factors for TD: having taken lithium prior to a TD causation medicine, also being a slow or very fast metabolizer of drugs metabolized by the CYP2D6 enzyme. And so that is what that specific enzyme is used to break down and utilize the medication. So based on how your body metabolizes that medication also impacts the level, the therapeutic level of the medication that is available through the blood-brain barrier. So we've hit on a few of the things already that impact on quality of life. And we've mentioned the aspects of daily life. But here are some items that we haven't covered. So it definitely can have an impact on employment, career pursuits. If TD impacts your physical ability to perform job duties, there may be a change in career needed. Personal relationships can become challenging and taxed, even within the most patient and understanding relationships with your family, spouse, partner, best friends. It takes some educating on both sides, yours and your loved ones and friends, and maybe even your employer. Dating and social life, that's a tough one as well. TD is not as well known as some of the other movement disorders. And as we know, we as humans interact with each other and assess each other by our facial expressions. And so it can definitely be a daunting task to, one, even consider dating and maintain a social life, for those reasons, and also for some of the fatigue that people with TD experience. So some hobbies and interests may become impacted depending on if the severity of the TD movements, or um, where the movements occur. For example, if a hobby revolves around fine motor skills, like knitting or putting together models, or detailed painting, that might be incredibly difficult if TD movements affect the hands and fingers. Living with TD can definitely have an emotional, or your outlook and self-esteem can become a bit damaged, um, or feel very poorly about the outlook of what your life will be like living with TD. Um, that can be overcome. It takes practice, but it is something that can happen, and there are support mechanisms out there that can help. And then the general activities of daily living, things that are identified as showering, getting dressed, preparing and eating food, um, doing your laundry, cleaning your house, washing dishes. I know I struggle with washing dishes. Soap is slippery, and I have impaired fine motor skills. And so that can be a challenge.
April, I want to thank you very much for all this information. Just looking at the time that we have left.
Yes.
Maybe I'll let you wrap up this slide, but I want to make sure we have time for questions. So.
Okay. We went over that information real quickly. Percentage of people that have reported and these specific impacts on quality of life, and they additionally experience severe anxiety or depression. The eating and swallowing is impacted and impacts self-care. Conversation with someone that you notice exhibiting the involuntary movements. I would have to stress being gentle and kind when possibly bringing this up to someone. Definitely discuss it in private. Very sensitive subject. Let them know that you care, there's treatment, and to speak with their doctor. By no means, don't stop taking your medications or adjust your dose without consulting your doctor. I can't emphasize that enough. Very important for screening. I know Bill already covered that. And also that there are FDA approved treatments for TD, valbenazine, which is known as Ingrezza, tetrabenazine, which is known as Austedo. Those are the two FDA approved treatments. They are VMAT2 inhibitors, but there are also off-label options that people choose, such as clonazepam, benzodiazepine known as Klonopin, amantadine, which is also off-label, and then some choose a natural route with ginkgo biloba.
Yeah, I'd like to open the floor to questions from our special guests. Anyone who has a question, please use the react button to raise your hand, and I will make sure you get called on. In the meantime, one quick question I had, and this is either for for you, Bill or April. If I'm a gastroparesis patient, what is the first sign that I might be keeping an eye out for tardive dyskinesia? What's the first symptom I could possibly notice?
You want me to answer that one, Bill?
Oh yeah, go right ahead, please.
Okay. So the most common movement would be with the eyes, lips, or face.
Mm-hmm.
So something along the lines of lip movement, jutting to one side, or
Okay.
rubbing, or even puffing out.
Okay. So something subtle.
Yes, it can be very subtle.
Yeah.
Yeah, as
Thank
far
you.
as the eyes go, I think blinking very rapidly is pretty common, and something that you might not see so much if you're with somebody, unless you're really having a one-on-one a close communication. Would be movement of the tongue. If their tongue is moving and then constantly in an unusual way, they may notice it more than you do. But as people talk and open their mouths and stuff like that, you may see this tongue moving around like in an unusual fashion, and that's a really common sort of first one of the first symptoms that many people experience.
And sometimes it's inside the cheek like that. And like you said, it could be darting out, just it something, that
Thank you. Yeah.
subtle, but it still brings attention to itself.
Alexandra, you've got your hand up. Do you have any questions?
I do. Thank you. And thank you both for presenting. I have been an admin moderator for the G-PACT Facebook groups for very long. I don't know, probably more than 15 years. So we have thousands of members, and I tend to read every question. And it's interesting. I personally have been on Reglan for 13 years. I take it every day. I've never had any issues, thankfully. I'm aware of them, though. My background is in inpatient psych. So we had I've sat with many patients that have TD or other movement disorders. So what I hear a lot in the gastroparesis groups, pretty much most people have been tried on Reglan at some point. Usually in the emergency room, they're given like a higher dose of IV Reglan. My understanding from reading that the rates of tardive dyskinesia that are reported to the FDA are really, really low. So I appreciate that you covered that it probably is really underdiagnosed. My understanding was that tardive dyskinesia is more likely to occur with higher doses of Reglan and with IV Reglan over oral Reglan. I had read this in a study, and obviously too with the longer, more prolonged use of it. So when people ask, I have said it. I mean, for me, I take 5 milligram orally, only as needed. Where's my question going? My question was, what I hear all the time is people say, when they go to the ER, you're in a flare, you're vomiting, you're sick. The ER is going to give you this crazy cocktail of IV medications, and they'll usually give you multiple medications that we sort of know are not supposed to be taken together, but they kind of do it anyway. And like if you grill a pharmacist, they'll say, well, yeah, technically you shouldn't be taking like I'm prescribed Reglan and IV Zofran and Compazine. They'll give you all these drugs to get Phenergan, and like they kind of just leave it to the patient without really telling you, like, well, you shouldn't be. I cannot tell you how many of our patients are prescribed all these medications together. And many of them are on psychiatric medication. Many of them are on antipsychotics. Many are on atypical antipsychotics. Many are on bipolar so it's like these crazy cocktails of medication. And I think that there's like a lack of education being given to patients as to like not taking them maybe at the same time or not taking. So what I hear all the time is everybody in the group thinks they've had tardive dyskinesia in the ER when they've been given these IV pushes of I've heard people take 20 milligrams of Reglan, which is crazy to me. Is a very high dose with IV Compazine, with IV Zofran, with IV Benadryl, with, whatever the heck else. They get what I would consider an akathisia of like what they're pacing the room. They want to rip the IV out. They're crawling the walls. They feel like screaming. They're panicking, and I say, well, that's not tardive dyskinesia. That's a bad medication reaction. It's like, and I don't necessarily even think it's from the Reglan per se, right? Because it's like all these other, I hear it a lot with the Compazine. People, they're really pushing IV Compazine, it seems like lately.
Sorry,
And
Alexandra.
Haldol too. Sorry
Bill, did you want to jump in there, Bill?
Well, I was just going to say that, you were right to say that it sounds like akathisia, as far as like the severe agitation, where they're pacing and this kind of thing. That's much more of an akathisia reaction,
Right.
than it is a tardive dyskinesia. And I know it's hard sometimes to tell the difference, but akathisia has that inner restlessness where they just can't stand still. So, and also even though I think I may have mentioned in my presentation, if you get Zofran in an IV at the hospital,
Yeah.
you could have movements, even though
Yes.
it's not considered to be one of the ones that should be causing any tardive dyskinesia, because
Right.
it doesn't affect those dopamine receptors that we talked about are at the core of like a traditional TD kind of thing. You're right. You throw all those things together and you put them in an IV at a high dose. Lord knows what could happen. And it's tardive dyskinesia. The word tardive means late onset,
Yeah.
so it sounds like it's more like just an extreme sort of reaction to that cocktail versus a true tardive dyskinesia thing, which takes time.
Right. So how can we sort of advocate or help our patients advocate for themselves of like what can they ask for? I know you can't like tell us what to give each specific person. It's like what can they sort of say, because I do think it's this cocktail of meds, this high dose cocktail of meds that is more the problem than just one specific medication. And a lot of people are getting Haldol, for nausea. They're giving people to kind of knock them out. It's crazy sort of how ERs are treating chronic nausea, vomiting patients. To me, I mean, those are drugs I wouldn't want to take in that sort of.
Oh, what I would jump in and say, if I may, Bill and April, is as long as patients are aware of what signs and symptoms to look for as far as tardive dyskinesia or other types of dystonia, keeping that in mind when going to the ER and getting these complex cocktails of medications, those are things that they should be asking their nurses or doctors about. Like, hey, I'm experiencing this. Is it possible that it is a result of this medication or something? It's hard to stop someone from getting a treatment ahead of time because of the potential risks, but that's what we want to do here, help people understand what those risks might be, so that they can make educated decisions about what they're going to say when someone offers them a medication in the ER. Maybe they have a sensitivity to it or have had a history of involuntary movements.
If they are able to or have someone with them who is able to advocate for them, they should be informed of every medication in whatever cocktail is being dispensed, an IV or a pill, what have you, and identify each drug, a complete informed consent as to side effects and, how those medications are supposed to work. You can refuse medication, and that's another thing to know. If you don't agree with the treatment, you don't have to receive it, even if you're in the ER, unless it's going to be a life-saving medication. But that's where, one advocate needs to advocate for themselves or someone be with them to do so on their behalf.
Yeah.
I have that's a big soapbox issue for me. And I can tell you, I have taken doctors to task for just sending a nurse in with a pill and go, here you go. I'm like, absolutely not. What is that?
What is it? What does it do? Yeah.
Right. What is that? Why are you wanting me to take it? What do you expect? What are the side effects? And I want to know everything. I don't care if it is 0.0001%. I want to know what it is. So sometimes they like me, sometimes they don't. But yeah,
I think this is one of the big problems is what I hear is they just say, I'm here, and all of a sudden they're having this horrible reaction. And truly a lot of them run out before they even can sort of figure out what happened. So we're trying to like backtrack and figure it out. But I feel like that we could, I mean, it's not abnormal to have protocols for like emergency intervention for like a migraine or for gastroparesis, for vomiting. I mean, I see that it's changed in the last few years that they're giving these kind of different drugs than we used to get. And people are having these horrible reactions. I feel really bad because then they're just put off. They don't want to go to the ER. They say, last time I went, I had this horrible experience that they say it was, like Bill was saying, so extreme that it was almost like the worst they've ever felt, the most panicky and just, indescribably awful. And so I feel horrible for them. I think it would be helpful to have some education about it in the groups. So thank you all for sharing.
Sure. Alexandra, I want to encourage, maybe we have a conversation after this is over. You're talking about putting together educational materials. That's part of our mission. Let's work together on that.
Okay.
Okay?
Yeah.
So please reach out when you have a chance.
Okay.
I'm easy to find. I'm all over the place.
Yeah.
One other quick thing I might mention on that note, and I know that we had talked about akathisia before, real briefly, is that akathisia can start when you start a dose, change a dose, or come off a medicine. So that's where the difference really between tardive dyskinesia takes a while for it to happen. Akathisia can happen as soon as you start something.
Sure.
And that's, so that's a big difference there. I just wanted to emphasize that.
Yeah, I appreciate that. I've always thought of tardive dyskinesia as something more with chronic use. To me, when you get something in an IV and you have this sort of immediate reaction, you're having something else go on, and I'm sure it's terrifying. Yeah.
Well, thank you all for coming to this important webinar. To Bill and April, thank you so much for the generosity of your time and experience. We really do appreciate it. Alexandra and others for questions. This has been very, very helpful. You can expect to see this webinar processed and added to our YouTube channel soon. And if you have any additional questions about tardive dyskinesia or any other symptoms, reach out to us. We are very close friends now with the National Organization for Tardive Dyskinesia, so we'll be sharing information as needed. Thank you, everyone, and have a great day.
Thank you, Jim.
Thanks for having us.